My name is Anna Brogan, and today we're going to be discussing my change project. My change project was implementing bedside report in the emergency department. I chose this project because it is something I'm passionate about. I took over for a patient not too long ago, and there was no bedside report. This was a very critical patient. A sentinel event occurred, and it was just a poor communication between staff, and I felt like the patient's care could have been drastically improved had there been a bedside report. The goal for this project was to increase bedside report as a standard practice in the emergency department at the hospital I work at. The objective of this project was to develop an effective program for bedside report during each shift change to promote paramount patient care and clear communication amongst coworkers in the emergency department at Princeton Community Hospital. This change project has been implemented by November 15th, 2019. Princeton Community Hospital, which was the location that the change project took place in, is a small community-owned hospital that serves a lot of people with a lot of different things going on. We are our only local trauma center, so we get everything. We have very critical patients, and it is very important for the nurses to provide excellent patient care, have clear communication about that care, and also have excellent documentation, because in 15 years when we go back and someone has opened up an issue with their care, we are not going to remember what we've done unless it's documented. And by having bedside report, we have a last jog of memory to do all of that documentation, make sure everything is clear and precise. Identification of the problem. There were some restraining forces to this project. The first was a lack of staff acceptance of the new practice. Now, since the change has been implemented, staff has been way more accepting than I expected. But there are some nurses that have done certain things for 30 or 40 years and they're not changing, and that's okay. There's different strokes for different folks, but that is a restraining force. Lack of management enforcement. Our nursing manager in the emergency department is extremely stretched thin. She takes care of a lot of stuff for a lot of different people, and she doesn't really have time to take in another thing to enforce with her staff. She's concerned with enforcing that the staff provide good care and show up to work, so that is definitely a restraining force. A shortage of time for bedside report. After I have worked 12, 14, or 16 hours, which is my legal limit, I am tired. I don't want to spend any more time at the bedside. I want to take the beds and throw them out the door. I want to go home. So a shortage of time for bedside report is a restraining force, but it only takes a few minutes to provide such an excellent change and an improvement in patient care that every nurse can spare. Nobody's in that big of a hurry, and if you are, you need to reevaluate why you're a nurse and what you're doing. Misunderstanding of the purpose of bedside report. A lot of people think that bedside report has to be something complicated and that it has to take a lot of time, and it's there to shame the other nurse, and it's not. Bedside report is not for you to ask the other nurse, why didn't you do this, or why was this done this way? It's to say, okay, that's what needs to be done, I understand, and to ask any questions that are constructive, not constrictive. Driving forces for this project were a need for clearly communicated patient care. If I am the patient, I want the oncoming shift to know that I've asked for pain medicine 35 times, that I have an open fracture that I need antibiotics for within 30 minutes. I want my oncoming shift to be aware of my care, be aware of my wants and my needs for this stay in the hospital. Safe patient outcomes. No one wants a sentinel event to occur as a nurse or as a facility. We don't want a patient to get an unnecessary infection, have an unnecessary delay in care, or possibly a delay in surgery, any of those things. Proper nursing documentation. We are preached documentation from the time we step foot into an ASN nursing program, and that's because it's so critical. If it's not documented, it doesn't happen, and through bedside report, you have a last jog of memory to think, oh boy, I didn't document those restraints, or I didn't document that catheter, or those life-saving drugs that are keeping this person alive. It's very important that all of those things are documented, so in years to come, if you need to go back and look at your documentation, you can think, oh yeah, I kind of remember this situation, I see why I did that or why I didn't do the other things. Description of the environment. This is a picture of just a normal ER room, a normal trauma room. We have intubation stuff, things for all kinds of life-saving interventions, and it is a very serious environment. I don't think any nurse realizes when they're in school exactly what they'll see every day. They never expect to hold someone's organ in their hands as they're dying. You know, there's certain things you can't prepare for, but it's something that is part of our job. We love our job, and it's just part of the environment we work in. This is a picture of bedside report in the emergency department. It's not an elaborate situation. The nurses don't have lots of time to drink their coffee and talk about their patients. It happens very quick at the bedside. The patient is hopefully involved if they are alert and oriented. This is the entrance to my emergency room that I work in. It has right here that this change project took place in the emergency department at a local hospital. This is the little door for a whole lot of excitement. Okay, before compiling this project and completing it, I developed a needs assessment, which was a questionnaire completed by 12 ER nurses that were just yes and no questions. The first one was, do you feel that the shift report process currently practiced in the emergency department is effective? There were 7 no and 5 yeses for this question. I let the answers be completely anonymous unless the people wanted to put their name on it, because I felt that I was more apt to get the truth out of them. This first question was the most important really to me, because it told me that there was a larger majority of people that needed a change and did not feel like what we were doing was the best practice. Have you ever participated in bedside shift report in any facility? There were 2 no's and 10 yeses. That question tells me that we're behind. If every other facility these people have worked in are participating in bedside report, there has to be some reason they're doing it. It doesn't mean that it's completely correct or that we're doing anything wrong, but it tells me that the majority of people believe that there are benefits in bedside report. Do you feel that bedside shift report would be beneficial in our department? There are 4 no's and 8 yeses. Would you be willing to be a part of a small committee with meetings lasting 15 minutes or less who help pioneer bedside shift report in our emergency room? There were 5 no's and 7 yeses, which is fine. Some people just don't want to have time, or don't have time and don't want to participate in another thing to take up their time. When would be the best time to discuss bedside shift report in the ED? All participants responded that 7 a.m. is the best meeting time, and there were 3 recommendations for Saturday or Sunday meetings, as the ER is usually more calm to start off weekend days. Now, not all of our meetings took place on the weekend or at 7 a.m. We tried our best to keep it that way, but we needed to talk about things some during the week as well. Saturday and Sundays are the best time for meetings. There is less staff there, less distraction, and it's easier to get in a quick meeting and get everybody out and back to their jobs. Now, there were some comments. The comments I received were some comments for praise about the implemented change. One comment said, ain't nobody going to do this. I believe that was from a friend of mine, but that's fine, whatever. And 3 comments advocated for the meetings to be held on the weekend mornings, which was great. Action plan. Okay, a committee of nurses was established to commit faithful implementation of this change. Bedside report is, these are my actors. This is us actually giving a bedside report between 2 RNs with the patient. We recognize the benefit of bedside report, which is improved nursing documentation is a huge benefit of this change. This is a nurse in our local ER implementing the change of bedside report in her nursing documentation. Then we also established this tool, which is called ED Cope. It's just a badge reel tool to put on your badge to say, hey, this is what I need to communicate in bedside report. The front says, before you clock out, report at the bedside. Bedside shift report is the last tool for the best care. The ED Cope stands for, I can't read this for anything, extenuating circumstances, which is what brought this patient to the hospital. The doctor's involved in the patient's care. Their code status, because it is very important that we don't try to code someone that is a DNR. We have got to honor everyone's wishes, even in dying. Objective of care. Does this patient have an end goal to go to rehab, to go back home? What is their end goal? Physical interventions. Is this patient intubated? Are they on a pressor for their blood pressure? Are they being externally paced? What's going on with this patient? What have we done for their care? The last one is emergency contacts. When something goes terribly wrong with a patient, which we all know can happen in the blink of an eye. A patient can be sitting up and be fine, and then the next minute be completely not okay. We need to know who we need to contact, whether this patient is a ward of the state or they have a son, daughter, mother, whoever. We need to know those contacts. Helpful items. The badge rule tool obviously was the main tool that I implemented for my nurses to have something simple to go by. Snacks were provided to those in attendance of the in-service. Just about any nurse can be bribed with a little bit of food because we never get to eat. Flyers posted around the ER regarding bedside shift report information. The flyers were posted, as I have previously mentioned, in the restroom because that's the only place we get to sit down for a long period of time, in our snack room, and then in other bulletin boards around the ER. A suggestions box was placed for helpful hints for bedside report and successes, failures of this change. I've only got 2 helpful hints suggestions in my box, and those both were kind of encouraging bedside reports. So I haven't gotten really anything great in that box yet, but it's there in case anyone needs to give me a suggestion anonymously. Guidelines. Bedside report is for all nurses and people involved in the patient's care. This includes EMS, EMTs, whoever is bringing me a patient. I don't care if it's the patient's family from their car in the ambulance bay. I want some kind of report. What happened? When did this occur? What's going on? Bedside report only takes place at the bedside, not at the nursing desk. If you do it at the nursing desk, that defeats the purpose. I want to physically lay eyes on this patient so we can talk about him and I can know actually what's going on, because you can say that a patient looks fine and every nurse might have a different perception of those words. Bedside report badge rule tool, the ED code information, which I already went over, and it's much clearly written right here. Review nursing documentation after bedside report before clocking out. After you give your bedside report, you have to go back to the computer anyway to make a note that says I gave report to so-and-so at this time. So take this time to say, okay, I need to put a stop time on this fluid, I need to make sure that I documented those restraints, all that stuff. Maintain a positive attitude of each other's attempt at bedside report. Like I said earlier, bedside report is not the time for you to be the best nurse and the person leaving to be the worst nurse. It is the time for you to ask questions that are actually pertinent and not to shame someone, even if you feel like they haven't done something that you would have done. Go live, the November 4th in-service was a big success. Everybody was responsive and I think it went very well. The staff gave me a lot of good feedback, positive suggestions, and everybody was very excited about this. What worked well, what didn't work well? Staff were overall supportive of the implementation of bedside report in the ER. They were willing to begin practicing bedside report today, which was awesome. Everybody said, okay, let's do this. We're going to do this first thing this shift. Staff expressed that they were thankful for the change towards bedside report and its likelihood of improving our nursing documentation. Every nurse knows how important that documentation is. New nurses were excited for bedside report as they felt this would make them more comfortable with the critical patients they were assuming care for. A lot of nurses, if they're giving report to a seasoned nurse giving report to a new nurse, thinks that they automatically understand what's going on with the patient. They understand these vent settings and NG, OG, all those things. And new nurses don't. They are scared to death, especially in the emergency room, and they just want to survive. They need you to physically say, this is how this suction works for this vent, etc. The nurse manager of our ER reports that the practice of bedside report will be used as information for new hires. Staff were very concerned, these are that didn't work, about the amount of time bedside report could take. Staff were concerned that bedside report could be made mandatory. The word mandatory makes things just more difficult to accept. Everybody is much more likely to do something that is a choice as opposed to something that's mandatory. Some difficulty getting both day and night shift nurses together for meetings. Night shift is exhausted and day shift is still asleep when we come into work, and this is always going to be an issue and something that we just have to deal with and try to accommodate both shifts. Some difficulty having nurses participate in the meetings so early in the morning, which goes along with the before mentioned issue. Nurses are asleep or too tired and exhausted from their shift. All right, always remember that bedside report is short, sweet, and less than a feat. I came up with this little saying because bedside report does need to take a long time. You do not need to include this patient's ancestral background. You just need to say, this is what we've done, this is what we need to do, this is the plan for this patient, and include all that ED code information. The nurse coming on does not care if the person's toenails are pink, unless they don't have toes, and that's something important. And it's less than a feet. Bedside report is not something to be stressed, it's something to help us. It is a change in the right direction for patient care, and it's not something to be stressed. So that is it. This is me. This is my contact information. I've been so thankful and lucky to get to implement this change, and I've been so blessed by the people I work with because they've been so supportive and accepting of this change. Thank you very much.